we had some, well, I'll give Ray credit for this one. Ray had came to me and she wanted to talk about fractures and dislocations and how do you reduce them because it's not necessarily taught much, and if it is taught, it's not taught well in medic school. So you guys get one attempt prior to doing a reduction, or one attempt overall for a reduction. So it's important that that first attempt, if you're going to do it, is worthwhile. So we'll start off. So some basic concepts, and this is just to kind of clarify some points of broken bones and dislocated joints that we have ran into in the ED. So Dr. Wells wanted me to throw some stuff in here about this. A deformity is not a contusion, bump, or laceration. We get a lot of that, not particularly from you guys, but we get it from other people. So just to clarify, a deformity is an angulation of a limb where there shouldn't be, aka a joint where there shouldn't be, or a deformity that's obvious and doesn't allow a joint to function. So dislocated shoulder, obvious deformity, arm at a 45-degree angle, obvious deformity, arm that got a bruise on it, not a deformity. And sometimes contusions can mimic it and there's swelling and other stuff, but a deformity should be pretty noticeable. If you move a limb to position it or assess the patient, this doesn't count as a reduction. So if you're picking up a leg and all of a sudden it goes whoop, that's a deformity. Sometimes people land and their leg's straight and then all of a sudden it's bent and we can tell that there's a deformity there. A reduction is a purposeful attempt to put a limb back in its normal alignment. For you guys, there's only one attempt to be allowed in the field per patient encounter. No, you can't have everybody in the truck do it. You can't have your medic student do it, plus you do it, plus the lead do it, plus me do it. One attempt. Indications for reduction for you guys is a neurovascularly compromised limb, aka pulseless. And Leslie, is there something in the protocol about like neurologically dysfunctional limb? I didn't look that far. So okay, so just pulseless. Once a reduction is performed, splitting is in the proper anatomic alignment and location is the most important part of all of this. And then there's been some questions about what are we allowed to do with fentanyl, Versed, are we allowed to mix them? Basically, if you combine any two sedatives, ketamine and fentanyl and Versed, whatever you have, it counts as a procedural sedation, and as of now, the state does not allow this. So you just have to pick one medication and go with it. Or you have to call for orders. So reductions are fairly simple procedures with a relatively low risk of worsening the injury. That's the most important part of all of this. You're not going to worsen, like most people get scared because you're like, I'm gonna lacerate an artery or whatever. If that artery isn't trapped enough that you're gonna lacerate it, you're gonna lacerate it anyway. So relatively low risk of causing any injury when doing it. While it's not impossible to cause further injury, if you know what you're doing and you do it the right way, these are safe techniques. So basic concepts of fracture reduction. First step is always to pull traction. So you pull traction in the direction of the deformity. You accentuate the deformity in step 2, so you break it more. You just take that in that direction, and then what you'll do is you'll move the distal extremity into anatomic alignment, or slightly past the anatomic alignment. Sometimes that's necessary. So if you think about it as kind of when the bones break, they kind of key into each other. What you're doing is unlocking those teeth, and you're bringing it back into alignment. And all of these techniques are kind of like a semicircle. So if you're broke like this, you're going to pull traction, accentuate the deformity, and pull it back around and let it sit into place so it keys into place normally.
That's what you're talking about with the lady that you did? I'm so glad you did.
So it's not that hard. And some of these you can even just like kind of push over if they're that bad, like the lady that we had with the ankle. So number 1 rule, limb must be pulseless or showing signs of vascular compromise. So describing the injury. These are some things that you can think about when you call in. So the way that I think about something, and of course I have x-rays and stuff like that, but if I'm going to describe something to an orthopedic surgeon over the phone, they should be able to take a piece of paper out, draw it, and it should look exactly like the limb that I am describing to them, or the injury that I'm describing to them. So if you want to do your call-in, you're like, ankle's broken, 45-degree angle angulation laterally and rotated, I can tell you what that looks like. It's a foot that's off to the side rotated, right? So those are all kind of important things, and if you think about it that way, just describe what you're seeing and we should be able to hear it on the other end. If there's a laceration over the deformity, it's always an open fracture until proven otherwise. A deformity, when you're describing it, tell me what the angulation is, where the displacement is, so if it's lateral, posterior, anterior, etc. It's rotated. There's lots of different ways to describe a deformity. You can say that the limb looks like an S. It's S-shaped, and that's completely okay. And again, left ankle laterally displaced and angulated 45 degrees. And then the skin. Skin's kind of important with fractures, especially with age. So skin tenting, you guys have seen that before, I'm sure. There's also skin, like blistering changes. Those happen kind of hours after an injury. So if somebody's on the ground and you say like their skin blistering, that means that there's a significant amount of pressure causing third spacing of that fluid and causing blisters. Abrasions, changes in color. Changes in color is really important, especially with fingers. Because a lot of the time you're not going to be able to tell me there's a pulseless finger, right? But if the finger's purple and at a 45-degree angle, pulseless. So this is what everybody does. They go, ooh, bad leg. That leg is bad. Does anybody know? Can anybody describe that one for me? How you would describe that? Other than like brown fan status and might get amputated.
Near amputation of the foot, it's hanging on by skin.
Yeah. So think about it where it's at anatomically, right? So you know that's mid-shaft of the lower extremity, right? And you know it's an open fracture, it's an obvious open fracture. So what you could say is this appears to be a mid-shaft tib-fib fracture, open with large 10-centimeter laceration and rotated lower extremity. And then you know, depending on what you see, there is a small amount of muscle body holding it in place. But all of that's bad. That's not going to be good. So we're going to play a game. It's called Is This a Deformity? Oh, what did I do? Deformity? Deformity?
Yes.
Deformity?
Yes.
Deformity. Is this a deformity? Lateral bursitis. Is that a deformity? So let's go back. What deformity is this? I'll tell you it's a leg. It's a knee. So how would we describe this knee? Yeah.
Posterior dislocation.
Posterior, yeah. So posterior knee dislocation. Perfect. What's this one? And posterior knee dislocations. Good, bad, in the realm of knee dislocations, good or bad? Bad. Where's all your vascular structures for your knee? In the back. Deformity? How would you describe this one? Correct. So this has an epidem. This is called Colles fracture, but basically, distal radius fracture posteriorly displaced and angulated would be the easiest way to do it. Because you're describing, when you describe the displacement, it is in the distal segment of the bone comparatively to the proximal segment. So if you're looking at something, it's posteriorly displaced distally, right? This would be a posterior, or if you want to get fancy, there's dorsal and volar parts of the hand. That would be a dorsal displacement of the wrist. This one?
Posterior dislocation radius and all.
Yeah, posterior displacement of the radius and ulnar, or posterior elbow dislocation. This one?
Anterior shoulder something.
That one? Is that a deformity, not a deformity?
Friends, I actually have had a patient who has something similar to that, and he has schizophrenia as well, so he was going to say, I broke my shoulder. And if you didn't know him, he had a huge knot
Right there.
right there. He's like, look, see, it's broken, I can't move my arm. And the second time I went to him, I figured it out. I was like, okay.
It ain't broke.
This guy's okay. Yeah, he fooled me once.
So this guy is not schizophrenic. We'll pretend he's not schizophrenic, and he fell on his shoulder. So this is a clavicular fracture with caudal, or I guess technically cephalad displacement, but caudal skin tenting. So skin tenting from clavicular fracture. All right. So now we play a game of how would you reduce it. So Colles fracture. Yep. So pull traction, pull it up over, get it in place. Ankle fracture. That's a pilon fracture, very similar to what we had. So typically trimalleolar. So you have all three pillars of the ankle broken. How would you reduce that? That's really easy to reduce, by the way. Yeah, you can just pull and rotate. Most of the time you can pick their big toe up and bend their knee, and it'll just slide back in place. Finger.
Pull my finger.
Yep. Fingers are the easiest thing to reduce. You go, oh, hey, let me take a look at, whoop, and it's back in place. And that last one. There ain't no reducing that. You can rotate it in place and split it. All right. So on to joint reductions. So anterior shoulder dislocations. There's multiple techniques for an anterior shoulder dislocation. There's traction counter traction, which you'll see us use a lot. That's where you put the sheet underneath of them and you kind of pull their arm out into place. There's the fast, reliable, and safe technique, the Ferris technique, which nobody uses. There's the Cunningham, Davos, Snowbird, Eskimo, Coker, Milch, Stimson. There's a whole bunch of orthopedic surgeons who wanted their name on shit. Excuse me. And then scapular manipulation. Contraindications are if they're not neurovascularly compromised or if it's a chronic dislocation, meaning greater than 4 weeks. And there are people in our community that have them. The techniques that you guys will be using most often, traction counter traction. So the way that you do this, you put your patient on your stretcher, you have one person hold traction in one direction with a sheet, goes into their axilla, you wrap it around the torso. The easiest way to do this, in my opinion, is to take 2 sheets, tie them together, and wrap one around somebody and have them sit on the bench. And they will hold that person in place for eternity. The other person can wrap a sheet around themselves if they're feeling so inclined. They can have a cool belt. And you can tuck that sheet into their elbow. You flex their elbow up, and you just bring it out to about 90 degrees. And you give it a tug and kind of a rotate, and it'll pop back in place. The other technique that I recommend is something called a Coker technique. This is probably the easiest thing to do at any point in time if you want to do it. So you can place the patient supine or seated. You'll take the arm, push it as far down as you can, and bury their elbow into their side, and then you just rotate their arm outward. And as you externally rotate, you overcome the the greater tuberosity and it kind of pops back in place. You can also do it by lifting their arm up to 90 degrees. This is really easy to do without sedation. You just kind of talk to them, shake their hand. Normally what I do is I take my knee and I bury it into their elbow to force it into their side. And as we rotate out, so if you think about it, if this is my elbow, or this is their elbow getting pushed in, my knee's here, I just take their arm and rotate it out and it'll pop back in place. We do that a lot in triage for the people that can tolerate it. Some people have done it on the stretcher while you guys are still sitting there. Works pretty well. Something else called the Eskimo technique. If you're really feeling ballsy, you can just pick them up by the arm and it'll pop back in place. I wouldn't recommend that one. Posterior shoulder dislocations. You are never, ever, 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 ever going to reduce these. Most of the time they need reduced in the OR. I think I've had 4, they've all gone to the OR. Most of the time you get trapped. Your glenoid cup, if you're looking at it anatomically, kind of sits with a tilt to the forward because you do everything forward. You don't reach back here very often. So once it gets behind that glenoid, it's hard to get it back around. Inferior shoulder dislocations, fairly common. There's one technique for it, and that is to get it into an anterior dislocation. So most of the time their arm's going to be stuck above their head. Most of the time you're not going to get their arm down. But if you can get their arm down and you can force pressure into their axilla just with a fist, you can push that humeral head anterior, and then they're in an anterior dislocation. They'll be sitting like this, and then you can do your second reduction technique of whatever you choose. Sometimes direct traction just above their head will put it back in. Elbow dislocations. Anybody seen an elbow dislocation? Anybody seen a reduction of an elbow dislocation? They're pretty brutal. So the main thing is to stabilize their humerus, have them at 90 degrees. You're going to supinate their forearm. Supinate is up, and that is because you hold soup in your hand when it's hot. Don't ask me why. I just learned that at some point in time in my medical school education. And then you're going to provide, as you hold their humerus, you're going to take your other hand and provide downward and forward traction. And sometimes it's not just hold their humerus, it's stick your foot in their humerus and pull. And it'll reduce. And something is going to break, and then they're going to go to the OR because they had to break something to get their elbow dislocated. Wrist dislocations. Treat it like a wrist fracture. Pull on it and push it back in place. Most of these wrist dislocations are complicated because you tear all of the ligaments in your carpal bones, and there's carpal bones flying all over the place. So just try to get it into normal alignment and bring it. Keep in mind that there's a close association between nerves, vessels, and bones in the wrist. Everybody knows about carpal tunnel syndrome because your nerve is very, very close to your carpal bones, and it often gets entrapped in these. Finger dislocations. If their finger looks like that, pull on it. It's not hard at all. Most people get weirded out by it, but you just kind of grab it, pull traction. Sometimes you have to wiggle it a little bit, put pressure on the actual joint line and where it's dislocated, and then you just kind of pop it back in place. And most of your dislocations are posterior. So what you'll do, you'll just take their finger, you'll pull it, extend it, pull it over, and it'll go back in place. Not too hard. Hip dislocations. You're never going to do these, but they're really funny. So there's the Alice maneuver, Captain Morgan, the Waddle technique, backpack. There's a whole lot. If you ever feel like dislocating or relocating a hip, please pick the backpack method. That's the funniest. You literally get them to shoulder height and and like put their arms or their feet over your back like a backpack and stand up. Pretty interesting. The Captain Morgan, you'll see us do a lot where you just look like Captain Morgan. You step on the bed, you put your knee under their knee, and you just kind of do a calf press and it'll pop it back in. The difficulty with hip dislocations is that most of the time they get kind of impinged on the back wall because most dislocations are posterior. You think of your car wrecks, you hit your knee on the dashboard, and then bam, it's in the back part of your pelvis. It requires a lot of internal rotations. If for some reason you are out in the middle of nowhere, patient has an anatomic hip that dislocated, and you're 6 hours in, and God forbid you have to do this, please call me first. I'll walk you through it. It's going to require 2 people. You have to keep their pelvis down, or else it's never going to go in. Knee dislocations, these are important to reduce. These will be your vascular compromised patients. So most often, your vascular compromise comes from a posterior knee dislocation. Basically, you're reducing it. Think of it like a big finger. So you're going to grab the distal femur. You're going to have you or your assistant grab the tibia. You're going to pull traction. And you're just going to kind of grab the back of the knee and pull it back into alignment with a little bit of traction. When you reduce these, splint them at 15 degrees. That's really important. And then obviously neurovascular status. And if you reduce it, please tell me that you reduced it, because I have to get a CTA, because it can dissect the artery more often than not. Teledislocations. Everybody's seen one of these, right?
Mm-hmm.
Second easiest reduction to do. You extend their knee, and it goes back in place. Because if you think about it, every patellar dislocation that you've had, has anybody ever had their leg straight? You've had it before?
One teenager did
Chronic dislocation.
chronic dislocation.
Most of the time when these are acute, people will be sitting there like this, and they're like, I can't extend my knee, because every time they extend their knee, their patella hits their femoral condyle, and they can't do it. So literally all you do is you take your thumbs, you put a little bit of pressure, and you extend their leg, and boom, right back into place.
That's my weakness. Knees. Knees. I know it sounds crazy, but I've dislocated my knees so many times. Every time I see it now, I'm like, ugh.
Your knees and Jennifer's eyeballs, no affair.
Ankle fractures and dislocations, again treated the same, but ankle dislocations only happen when there's fractures, nearly all the time. I mean, there's maybe a couple cases of other weird things, but most of the time, these, if you think about the way that a tibia comes down, the way that a fibula comes down, it forms what's called a mortise. It's a channel, so your foot can really only go like this. If you dislocate laterally or medially, something's broken. Most of the time, it's both columns, so it's both tibia and fibula. There is also a posterior component of a tibia that's considered the posterior malleolus, and it's weird medical technical terms, but essentially that kind of stabilizes it so it keeps your foot forward. If that breaks, it's a trimalleolar fracture, and those are grossly unstable. These are like fancy ways to do it. The easy way to do it, in my opinion, is bend their knee to 90 degrees. So have them flex their hip, bend their knee, it deactivates their gastroc. Your gastrocnemius is your strongest muscle on your lower extremity below your knee, and it always pulls posterior laterally, every single time. So if you deactivate their gastroc, if they're not using it at all, and you have them flexed at that position, then you just squeeze their ankle and it goes back into place. Sometimes you have to disengage some stuff and do a little bit of maneuvering, but it's really not a hard reduction. Most of the time you can just push it back in place. And then the splint for this, what do we do for a splint for this? Posterior splint, stirrup splint. Both. Bueller? So I would do both. So do a posterior and then do a stirrup. Because it'll stabilize you anterior posterior and it will stabilize you laterally, and you'll have your best anatomic reduction. Ankle dislocation caveats. Again, most ankle dislocations are grossly unstable. We talked about disengaging in gastroc. If you grab their big toe and their gastroc is disengaged and you lift to the ceiling, it will go back in place. 99% of these will just go back in place. If you see us splinting somebody with this, after we reduce it, you will see me standing there holding their big toe and holding their knee in flexion. That's how we do it. There is some other weird dislocations that are considered midfoot or subtalar dislocations. They can mimic ankle fractures, they can mimic ankle dislocations based on the swelling because there's basically two vessels that go to your talus, and as soon as you dislocate your talus, all of those vessels tear. Those are so hard to reduce, it's stupid. They're like probably the worst dislocation reduction, because if you think about how your talus comes down, it connects to all of your cuboids and your navicular, and those are friction joints. So they're basically just bone on bone, and they have like little indentations and keys in them the whole way across. So as soon as you dislocate that, it's like dragging concrete on concrete. You can't really get it to go back to where it needs to go. So most of these are open reductions in the OR. When in doubt, treat it like a fracture. Traction is always a good option. You always want to worsen the deformity and then reduce to anatomical alignment. Sometimes, as with anything, it takes a lot of force. Sometimes it only takes a small force. You can circumferentially squeeze around the ankle and say that you're assessing, and if it magically slips back into place, voila, your reduction's done. But you didn't burn your reduction attempt because you're just assessing the ankle. If you actually make a motion to like forcefully go, I'm going to reduce this, then call it reduction. But if you're just squeezing and going, oh wow, it's back in place. Good for the patient, good for you. Toe dislocations, just like a finger. Yes, it's a foot finger. Just treat it like a foot finger. All right, this is the part where I leave it open to questions to you guys. There was a whole lot of stuff in there, and this is how I'm going to burn my other 30 minutes. So,
Can I come up and you physically show us how to
Yeah.
do each one of those? I'll be your patient, so, because I'm sure.
Yep.
Physically seeing it's gonna help put into.
Yep.
Hi.
all right, so anterior shoulder dislocations. So the easiest thing that I typically do, so Coker technique, is you grab their elbow, or if they're sitting, you put your knee into their elbow, you push it in, you go, hey, can I shake your hand? And you go like this. And you just keep that pressure in. Don't let them run away, you don't let them move. You say keep your shoulder against the bed, and you just whoop, and it goes back in. That's the most often. Now it requires some force. It's not like a because you're gonna get to here and they're gonna go ow, 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 and start fighting you. And you wait there for a second. You go, hold on, a little bit more, and eventually you'll get thunk. You're like, okay, you're good. That'll be the end of it. Traction counter traction is kind of the same deal, except somebody's holding traction, right? And what I do is I just flex their arm up. If you want to be fancy, you can do this thing and hold them in place, right? And you just kind of pull. You lean and you pull. And you put, and it's your body weight. You're not going to hurt them. You're not going to magically tear a whole bunch of stuff. You just lean back. So that's anteriors. Questions on anteriors with those demonstrations? All right. There's something called a milch technique. We can cover that one too.
When you reduce those, should they become pain-free with full range of motion after that?
Yes. They're gonna be achy. Like I dislocated my shoulder last night on being an idiot. And I'm still achy, but it's not the pain of a dislocation. They're achy in there. And they'll have some swelling. They'll be like, it kind of hurts to move. They'll be weak to move, but they can get the biggest thing with dislocations is that they get external rotation back. Because normally what happens is they're stuck out here and they can't do this because what's happening is as they rotate, their greater tuberosity is catching on that glenoid as they move. There's something called a milch technique, which some people swear by, and I think it's kind of cool if it works. You basically have them comb their hair. So if they can get to here, most people can do this. If they can get to here, you have them comb their hair back, and then you force this into external rotation, and it'll pop. So where do
There's a priceless list.
yeah. So where do most anterior shoulder dislocations happen? Like what position are people in? Yeah, they're out like this. So they dislocate up here. Posterior dislocations happen from falls forward, seizures, stuff like that. So most people are up here. If you can get them into the alignment of their dislocation, that's where they're going to reduce. Because what happened was they had a force on a lever arm that caused the reduction. Once you get them back to that, without that force on the lever arm at the end of their arm, they will reduce back into place. So you just kind of return the alignment. It's like delivering a baby backwards. That is a technique. It's called a Savinelli. I had to do it once. It wasn't fun. All right. Inferior shoulder dislocations. Most of the time they are stuck up. So they're going to be stuck like this. They're going to have their hand behind their head. They're going to be doing something like this. The technique is legitimately you put your hand in your armpit and you push down. Because you will feel the humeral head in their armpit. As you push down, they're going to drop anterior. That is when you rotate. And that'll put them back into alignment.
And that does not count for 2 reductions.
No, that is one reduction because it has to take 2 steps to get it back into place.
Every single shoulder dislocation I've had as a patient has been where their arm is down like this.
They will do that every single time.
Like that's the only
So that's
position I've ever seen a shoulder dislocation in.
So that is what happens. So when you anterior dislocate, all of your muscles just like fail, and you're just like your arm just dangles. Some people will hold it out like this. Some people will hold it down. Some people will have it here, but it's always kind of like this anterior. It's considered like an anterior inferior, truthfully, but it's not a true inferior shoulder dislocation. Those are gnarly to look at. If you ever want to Google something fun, look for arthroscopic pictures of an inferior shoulder dislocation. It like goes through all the ligaments. It's pretty gnarly. All right, so elbow dislocations. So elbow dislocations are going to be posterior. So their elbow back here. You want to stabilize their humerus, and normally I stabilize it against their body. And you're going to put your thumb basically on their ulna, right? So you're going to push down right into their antecubital fossa, and you're going to pull down and forward to do it. Because you have to, what happens when it goes posterior is that your anterior olecranon breaks, and that gets hung up. So you have to disengage that. So you're pulling down and then forward. Now, you can stick your knee into their elbow. You can do a whole bunch of things so you have more traction, more lever. You have 2 hands to do it. Those are all ways to do it. These will typically not be neurovascularly compromised though, because all of your vascular structures are anterior there. The only thing that's ever going to be really compromised is your radial nerve, which you're not going to, you guys won't be reducing for that. wrist dislocations and wrist fractures. Good job. He likes to lick. I told you he's a cat. All right, so wrist dislocations. So most of the time, displaced one way or the other, or fractures. So Barton's fractures forwards, Colley's fractures backwards. But your technique is, I grab their thumb, I find the fracture segment or the dislocation segment, I put my thumb on it. And you'll find a lip, like you can trace back and forth, you'll find a lip. Let's say it's posteriorly displaced. Your motion is traction, back, up, and over, like that. And you want to hyperflex when you're done.
That felt good.
Did it?
Yeah.
So
It's like a
that
chiropractic adjustment.
so all of these are kind of like a semicircle fashion fractures. Finger dislocations, sideways finger, pull it straight, not super hard. I don't know that I can demonstrate that. You literally, you grab it, you find the portion that is sideways. Like I had a guy down in Eastover at a nursing home and fell down and his finger was literally like pointed backwards down here. You just kind of grab it and you go, whoop, and it goes back in place. It's it's not incredibly complicated. And if it's open, you can still reduce it. Just having it, just it being open is like, it's fine. You just pull traction, right back and put on it. Just almost did it myself. All right. Who wants me to demonstrate the backpack technique?
Of course.
Knee dislocations. So knee dislocations are again big. They're going to be flexed to some degree. You're going to have something, but if it's posterior, you have somebody stabilize on top, and you just pull anterior, pull traction down, and you pull anterior. And these are all these are tests that we do. So there's something called an anterior drawer test that tests for an ACL. It's this. Posterior drawer test, this. That does test for PCL. It's literally the exact same technique. You can put your knee on their foot, you can sit on their foot, and you can just go whoop, and you can see how much I can move her. If you have the knee at 90 degrees, the condyles are disengaged, so you can just do it from this and not have anybody hold traction. Her weight's going to hold the traction. Okay? Ankles, like I said, you just squeeze. So most of the time they're contorted one way or the other. Most of the time they're lateral. Most of the time they're going to be hanging off this side. You can take the ankle. I normally grab above the ankle and below the ankle. So whatever side it's dislocated to, I try to grab high on the other side and then low on the side where it's dislocated. So let's say it's lateral, and you just kind of back in place. You're going to do a kind of traction, accentuate, and back into alignment. Now what I was talking about with the toe technique is you bend their knee up, you hold their toe, and all of a sudden it's back in place. But you have to get to this 90 degrees or else the gastroc isn't engaged. And if you do any of this stuff, they're just going to hate you, and it's going to flex the gastroc. Midfoot, good luck. And toe dislocations, just pull on it. Any other questions about things?
Thanks.
No good questions? All right. So we're going to practice describing fractures. These are going to be mostly x-ray based. You can see where I got the picture from. So, fracture, regardless of what Fayetteville says, is a broken bone. A fracture is always broken. So, patient evaluation, very important for fractures, is always age, mechanism of injury, If you can get their prior functional status, that would be really awesome. Like if grandma goes around in a wheelchair most of the time and she broke her hip, that's very important. If grandpa jogs a mile a day and broke his hip, very important. Any coexisting medical problems that they have, additional injuries, special situations, you guys are good with that. Pre-physical exam, always this stuff, but again, open versus closed injury, swelling, ecchymosis, deformity, is there tenderness, pain, crepitus, step-offs, what's their motor and sensation like, and what's their vascular assessment, range of motion, radiographs, x-rays, this is all doctor stuff that you guys don't have to worry about. So fracture description, is it open or closed? If you can name the bone, name it. Anatomic location, if you can tell me a fracture character, aka like, is it in multiple pieces, like segmented, you see bones flying across the road because they were just in a motorcycle accident, displacement and angulation. There's this fancy classification system that we use called Castillo-Anderson. It guides our antibiotic uses in the hospital. It's just something that's kind of interesting. So type 1, clean, skin opening less than 1 centimeter. That's type 1 Castillo-Anderson. And as you can see, kind of hard to tell that it's open other than there's a little blood spot. Type 2, lacerations greater than 1 centimeter but less than 10 centimeters, and there's extensive tissue damage. That's type 2 Castillo-Anderson. So these are the ones where like people start going, I'm not going to worry about their airway, breathing, and circulation because they got a broken bone. Type 3, this is extensive tissue damage, including muscle, skins, neurovascular structures. These require extensive management. These are typically your high mechanism of injuries, crush injuries, barnyard injuries, etc. So, anatomy. Start with the basics. What bone is it? You can tell me what bone it is? Great. What bone is that? That's not funny. Regional. You can do regional descriptions if you really want to. So diaphysis, metaphysis, epiphysis. That's really complicated, but most of your bone breaks are going to be in the diaphysis, which is the center of the bone. Anatomic location. Proximal, middle, distal, anterior, posterior, medial, lateral, etc. Long bones are typically divided into thirds: proximal, middle, distal, and there's junctions of bones.
Right.
Radius and ulna. Angulated, not angulated? Definite deformity, right? So, if you see the bone, you can describe the fracture line. Is it transverse, oblique, spiraled? Spiral goes up the bone and twists and breaks into like those stabby pieces that you see. Comminuted, there's multiple segments, so more than 2 parts. Specifically, that when they talk about comminution, it is fracture. It is multiple parts at the fracture site. So if you see somebody with a gunshot wound to that was a shotgun and it blasted their leg into pieces, comminuted, single fracture. Segmental fracture is that guy that you pick up his femur. He's gotten in a motor vehicle accident, and all of a sudden there's a joint high, there's a joint low, there's a joint in the middle. It just kind of turns into an S. And then butterfly fragments, you're probably not going to see unless they're on the road. So that's a transverse fracture. Angulated, not angulated? Angulated. And you can see that, so you can see that on the soft tissue that that's an obvious deformity with angulation, right? Anterior, posterior angulation. Posterior. And displaced posteriorly because of the distal segment. This is an oblique fracture on x-ray, but as you can kind of see, it's at an angle, it's not directly across the bone. Spiral fractures. These are your old ladies who stood up to go to the bathroom and they twisted, and all of a sudden, kablamo, they just broke something. So as you can see on this one, All of this is bright white up here, but this is less bright white. But it's bright white here and bright white here. So there's a segment down here that's less bright white that fits into there. So those are your torsional injuries. Accommodated fractures, multiple segments in the same fracture line. Segmental fractures and multiple pieces of the same bone. This is called a butterfly segment. This is when you fail to bend. Bones aren't supposed to bend, but they fail at some point. You get those. You can also describe it as intra versus extra-articular. So if you see somebody has an open wrist and they have a break and it looks like it's into a joint, intra-articular. Extra-articular is going to be pretty much your normal stuff. Displacement, as we talked about, is in regards to the distal segment of whatever it is. So the wrist is dorsally displaced or posteriorly displaced because of this fracture. Shortening, everybody talks about limb shortening. What are we talking about limb shortening with most often? Hips. Angulation we talked about, so that's no good. That's like 45 degrees.
That's what that foot looked like on the bottom, yeah.
Yep. Rotation, you guys can describe like they broke mid-shaft tibia and fibula and it's rotated around backwards, foot's pointing the wrong direction. You don't need to know about that. You don't need to know about that or that. Pediatric fractures are kind of weird. So you can have a fracture at your growth plate, considered a physeal fracture. There's green stick fractures, which are incomplete fractures because kids' bones are bendy. There's torus fractures, which are like impacted fractures. Those are the ones that you guys may miss because some kid fell out on his arm and he says it hurts right here and it hurts to touch. Well, he just buckled that area. So Seltzer-Harris has a whole bunch of different classifications that you don't need to know about. Green stick fractures, not all the way through. That only happens in kids. And then buckle fractures are those ones that kids fall down. They have a little bruise maybe right here and they say, it hurts right there, but it really hurts. You can't turn the wrist around, stuff like that. So diastasis, these are all kind of more complicated terms for joint injuries. So diastasis is a partial separation of a normally aligned joint, most often seen in pregnant women at their pubic symphysis during labor. Subluxations are partial dislocations, but not complete disruption of the articular surface. So you may see those. There are people that sublux and stay subluxed. And then there's displacements, total loss of contact. So these are diastases of different sorts. So that's a pelvic diastasis. What should you think of if you have a patient with an unstable pelvis that has that? You rock their pelvis, or their blood pressure is low and they just were in a car accident. Open foot.
Talking about at the bottom of the
Bottom left.
middle?
Yep.
My dad did one of those. He fell backwards.
Subluxations can be chronic, can be acute, but basically the joint kind of looks aligned but not aligned. Dislocations. Those are bad. Those are what you're reducing. And this is kind of what I was talking about with the elbow. See, you have your anterior portion, your coronoid process, because it's annoying that they named it something else other than your anterior olecranon. But it latches on the back in your olecranon fossa. So that's what you have to deactivate. If you are going to reduce an elbow, that is why you're putting downward traction. Does that make sense? How would you reduce that angle? Pull up and around. Get it back straight. Bad one, huh? So they're not shooting it straight on. I can tell you that. Because the bones aren't aligned right. But that is their actual angled joint, and this is where it's supposed to be. That down. Just for more education, these aren't fractures, those are growth plates. Sometimes you'll see somebody with something weird. This is a bipartite patella. Sometimes they're fused, sometimes they're not. Sometimes you'll feel like two patellas. It's normal. So, because we're ER doctors and everything for us is written in crayon because we're stupid, please describe to me finger injuries as thumb, index, middle ring, and little finger. Because otherwise I'm gonna go, wait, 1, 2, 3, because I'm knocking them down. You can talk about metacarpals as first, second, third, fourth, fifth. People are a little more simple when it comes to that because of, for whatever reason we like fingers to be named as fingers and metacarpals to be named as numbers. So if somebody broke their mid-hand, like boxer's fractures, right? Never going to be neurovascularly compromised, but you say there's a deformity of their fifth metacarpal. More doctor stuff. So, play the game of describe the fracture. We're going to pretend that it's not an x-ray and pretend that it's just an arm. Any luck? Bueller. Start with the right thumb. That's what you're going to notice. Angulated, not angulated, angulated. Displaced which direction? So pretending you can't see the bones, what would you say? You're looking at it like this, thumb forward. That kind of looks like that. Except I can't break my arm. We can't. Heck, I can, if somebody wants to, we can dislocate my shoulder and try to relocate it. So this is a wrist fracture, dorsally displaced and angulated. Simple. That one. What bone is that? Angulated, not angulated? Angulated.
See on the skin. Like, if I wouldn't see the x-ray,
I mean, on the one on the right, it looks like right in the armpit, it's kind of angulated. It's
Yep.
Just deformed.
Yeah, so you're looking at two separate views of it essentially, but essentially you can see this skin bulge here, so you're probably gonna see some deformity. So angulated with obvious humeral deformity, probably posteriorly displaced. This one, right, our patient? So,
Was that's from Our Lady?
no, but that's exactly what she had.
Gross deformity,
Gross deformity how?
or foot, ankle, fracture dislocation, anterior in front of tib fib.
Okay. Yeah, anteriorly displaced. That works. That one? That's tip fib. Laterally or medially displaced?
Yeah.
Laterally displaced. Open or closed?
It's open.
Open. So, open tib fib, distal third, 20-degree angulation, laterally displaced. That's bad. Has a special name to it too. Because why can't we be complicated? You guys are gonna see this and go, okay, there's a posterior deformity, but anteriorly displaced, short. That one? You might feel something squishy and they can't straighten their leg. Close.
The shard of the kneecap popped off.
Yeah, so that's a patellar fracture. Most of the time diagnosed with squishy knee and the fact that they can't keep their leg straight when you lift it up. Because you just separated two parts of a tendon, right? Bone right in the center of a tendon. All right. Does anybody want to do any of these other lectures? Wonderful lectures.